Welcome everyone. Hope everybody's safe and healthy, and planning to maybe for next week have a meeting with all the Long Island dentists that I know, like we did a few weeks ago, to update you on current trends. There's a Forsyth Institute's having a program tomorrow, Friday, on effects of dental practices. So I'll have information from that. I want to thank Leslie Hallis, who's our local representative with NDX nSequence, and she's in New Jersey at home right now and has helped organize this program. Then we have another program coming up, and also Jeff Carlson, who I've never met personally but spoken to many times on the phone. And Jeff has been a CDT for more than me, over 40 years. I'm practicing perio 32, so he's a little bit more experienced than me in both being in the lab end and the implant end, and has actually written a cookbook on restoring dental implants. He's done some training programs. He's been very active in implant dentistry. Currently, he's the nSequence implant specialist for National Dentex NDX, which is probably one of the largest chains, or the largest chain of dental labs in the US. And he lectures cross-country on immediate loaded full arch restorations, and especially nSequence guided prosthetics and latest advances in implant technology. That being said, today's program that we're going to be really talking about how to take proper records, problems the lab sees in records, as well as getting into some of the prosthetic options. We are going to talk a little bit. I'm having another person having a problem logging in. I'll send that latest link. So with that being said, I'm sorry about the interruptions and starting late. Jeff said feel free to hit the chat button on the bottom, and you can make chat right to any of us, and we'll see that. If you want to, I guess they can talk. They could raise their hand and they can talk during this. You have a hand raising button, Leslie, on this program?
Everyone is muted. Let me see.
Okay.
I think it's best just for we don't get too much feedback. Yeah, if they can talk, just chat that you have a question, and then we can unmute you.
Okay. So with that, I want to thank you, Jeff, for being part of this program and presenting this. And I'm going to give the stage to you, and you can add anything on to that introduction.
Well, great. Now, thank you very much, Dr. Farber. I appreciate it, and thank you all for joining us. And hope that everyone is safe and healthy there in New York. I'm in Minneapolis area, and they're still digging out of snow. Amazing, amazing. Again, thank you for your time today, and this is really informative. What I'm wanting to share with you are things that we see at the laboratory, at nSequence lab, cases coming in. Some of the common errors that are made, and whenever there's an error in records, it delays a case. And that's not good, because everyone's on a schedule with these. And as you all know, when you do these type of cases, you're not blocking out a half hour, an hour of time. It's usually a half a day or sometimes even more. So it's very important that we're able to have a good workflow, because we are combining digital workflow with analog workflow. And for some people, this is a little more challenging. It's new to them. And so my goal and objective today is really to make this as easy as possible and clear up any maybe misunderstandings that people might have. I know that many of you on the call have worked with nSequence, and so we appreciate that first. So I'm hoping that this will be some good information for you. So we're first going to discuss about digital records and our analog records to do an all-on-X full arch mediate case. So we're going to look at, for gathering records, there's really 5 areas that we need information from to do an nSequence case. Impressions, records, the scanning, we'll talk about those as well. Photos, very important, and then case submission. I'm very excited about how we've made some advances in the last couple of weeks. Some of the good news is when we have a little more downtime, we can get onto some things that we've been neglected to do. So let's talk about impressions. So we are able to receive both digital impressions and analog impressions. When we look at digital impressions, some of the things that we find that happens that causes challenges, and it's not necessarily as always you as the clinician doing the scanning, but when you're doing a scan and you're using one of your iOS scanners, and we're really looking for as much anatomy as possible, not just the dentition, but even the surrounding anatomy borders. Always think about a full denture when you're scanning, even though well, we do need to have you think about a full denture because we do want to be able to fabricate a backup denture for these cases, and we need to have all the landmarks, the tuberosities, retromolar pads, et cetera, peripheral border extensions, very important. But what's really been happening, some challenges that have happened, is that some of you that have this service, the way it's set up, when you do a scan and it goes to your, let's call it your server, to your company, and whether it's Itero or someone else, they'll take, and before the files, the STL files, what they do is called trimming, and they'll trim a file. And what happens is they're doing that to minimize some of the data to make the file easier to send and easier to manipulate. And they don't really think about what the anatomy that we need for an all-on-X case using our protocol. What I mean by that is that they're thinking many times, well, we're doing teeth. So they'll make sure that they capture all the teeth, maybe get 4, 5, 6 millimeters of the gingival around it, but we need more than that. So what you want to do is tell them not to trim the scans. So again, your STL files, do not trim them. Let us do the trimming, because that way we know what we're not going to lose anything. These images below are examples of incomplete scans, and the one on the right may look fine, and it is, except we can't make a denture from that. And these patients, it's very important to have backup dentures, because you can only imagine, not only do they have high expectations because of a lot of it's because of the cost, but it's life-changing for them. And so they need to leave, ideally they're going to leave with this fixed screw retained bridge, but sometimes things happen and they need to leave with a denture, but they need to leave with teeth. So we need to make sure that we have the ability at our laboratory to provide Dr. Farber with a backup denture. So that's a key thing that we see happen way too often, are these being trimmed in what's called like insufficient data. Doing conventional impressions, here again, just keep in mind we want as much anatomy as possible. We do find that sometimes these patients, look, a lot of these patients, they're dentally compromised. They're what we call a dental cripple. They're dentally exhausted as well. They've had failed restorations, failed teeth, or they just have not been to the dentist. They're not good dental patients, bottom line. And sometimes it's challenging to do a PVS impression, even though we like the detail of it, because of the, we don't want to necessarily do extractions at the time of impression. So alginates work well too. Preferred PVS impressions or scanning. Now, a little tip for you, if you have a patient who has really mobile dentition, throughout the process of records, you may find it beneficial to go ahead and just do some bonding, some composite bonding to stabilize the dentition, because we're also going to be doing some scans we'll talk about as we move on here. So if you do have a patient that has very open embrasures and you're worried about retention, trying to get the impression out of the mouth, block it out. Block out the gingival embrasures. What works very nice, quite honestly, is some Play-Doh. Use, because it's non-toxic, use a bright colored Play-Doh so it shows up. Green is a nice one to use, so if there's anything left, you can see it. So just some thoughts. Custom trays, when we're working with the edentulous arches, very beneficial to have. I can't stress enough the importance of anatomy, because we use so many different reference points, and unlike a lot of other laboratories, We've been doing this for 11 years, and we know what it takes to make these work. We do probably maybe 180 to 190 plus arches a month. That was prior to March. So we're very experienced at this, and we know what works. So I'm sharing with you things that, we call it nSequence because it really is a sequence of steps to follow. And I can promise you this, the years of doing this, that when you follow the sequence, the results are pretty predictable. The tendency many times for clinicians to want to either skip a step, take shortcuts, or modify steps. We still can make it work. It's just sometimes we find the result is you don't get the results that you expect from the case, which is really time saving, limiting or minimizing variables. So one other thing I wanted to share with you this is very important, and this goes beyond this tip. The next few slides I'm going to share with you are something I came up with a few years ago. And whether you're doing even regular denture work, forget about implants. What I'm going to share with you is very beneficial. We get a lot of study models in the laboratory, and we appreciate them. We appreciate photos, whether it's digital impressions, analog impressions, models, etc. But I wanted to share with you, when we get a study model, the concept of a study model is to tell the laboratory, it gives us the mold or the shape of the teeth, the arrangement of the teeth. And what it should do really is it should additionally tell us where do these two front teeth go, anterior, posteriorly, as well as incisally. As a technician, when we're doing a denture or doing a full mouth reconstruction, especially when it's the edentulous patient though, we have to find out where these two front teeth go and the labiolingual position, palatal position, and the incisal position. When we get that position correct, we get an accurate bite, good impressions, then we're able to give you a very nice result. So study models are lacking many times because what you see here on the two images on the left is very common. Well, the dental assistant take the patient's existing denture and we'll put it into an alginate tray. And what ends up, when they seat it like this, we see the arrangement, the mold of the teeth. Then you look from the occlusal, but many times we don't see the palatal area. It just does because of the vault to the palate here. So what happens is we lose data, information. So here's the tip. So for an upper denture, when they set it into the alginate tray, before it sets up, to roll some of the alginate material up over the peripheral border in the anterior area, mainly incisor area, just roll some material up. You can still leave the buccal peripheral borders exposed so you have something with your fingers to get a hold of to take the denture out. Secondly, and very importantly, is to push some material up over to the back of the denture in the post-dam area. We want to see the extension of the denture. Very simple thing to do, but when that happens, now look at the difference. When we roll up the material to the anterior area, looking at the right here, the laboratory can take a Bowley gauge and we can measure from the peripheral border to incisal edge. Now, instead of making bite blocks, so let's say if we're going to construct for you a new denture for a patient and you wanted to change vertical, but the patient really kind of, you like the length of the teeth, et cetera. Instead of making what we're taught in the laboratory to do, 22 millimeters for the rim and the anterior, lowers are 18 millimeters, and then you spend your time whittling away this wax with a hot spatula or something. By doing this simple little technique, we can really get zeroed in onto the correct incisal length. Secondly, by taking that posterior extension and getting that imprinted into the alginate impression, now we can take a Bowley gauge and you can see the outline right here and come out. Now we have a number here that will tell the laboratory the labiolingual or labiopalatal position. It's a simple little thing of putting the impression material over the anterior and posterior gives us information that many times we don't get, and that causes you more resets or more time modifying the bite block. So I hope you find that helpful. And just as a reminder, when you're doing your models, we want, this is a lot about accuracy. You're going to see in some cases that we really are putting implants. I won't say we're splitting hairs, but we're really squeezing implants in between vital anatomy and landmarks So accuracy is very important. So if you're doing your own model work, it's very good to go back to old school and use the graduate and measure things, so forth. Oops, sorry.
Jeff, we have a question.
Please.
What would you consider adequate anatomy on an STL file?
We want to get to the, if you can get as close as you can to the peripheral borders, if you can even get to within a couple of millimeters of peripheral border, we'd like to see muscle attachments. That's a very good question. Thank you for that, by the way. We want to see where the muscle attachments are. What this does, it helps us to fabricate a prosthesis that kind of minimizes your adjustments. So when in doubt, capture more than you can, and what you get is what you get, and we'll do the best we can with it.
And can you go back one slide for a second? There was a question on that.
Is this the
This
one?
one?
Got it, she said.
Okay.
Okay.
Cool. All right. Anything else?
Do we want to pause for a second? If anyone else has any other questions, feel free to chat them
I
in.
don't know if you're going to get into this. Maybe I'm ahead of you, but digital impression wise, is there certain systems you see do better for full arch than others?
Not really. They all work pretty well, quite honestly. I'm going to show you something I'll get to when we get into submissions. There's a spot on our website where, based on your system, I think we have like eight or nine different systems listed, that when you click on it, it'll give you some do's and don'ts with each system that we've worked out.
Mm-hmm. Okay.
Yeah,
All right, I'm going to move up.
Just with a dentulous patient, it's a little tricky to capture the cross arch with a digital scan.
Yeah, it truly is, and that's where maybe going back to the analog. This is where we can't get rid of analog technology. We need it, and even in the lab, we do both hands. We do a lot of still craftsmanship. We do a lot of customizing of the cases. So we still, shaping teeth and gingivals and wax ups and etc. So sometimes we can't get all digital, and it's just the way it is. So I'm going to talk about some records now, and how to get some of the accurate records and what we're looking for. A lot of questions we get asked: do we need a face bowl? And you think about, we're doing full arch reconstruction or full mouth reconstruction, that should be mandatory. Well, the reality is, when we're dealing with a CT scan, we're capturing, and I'm going to talk to you about the field of view and stuff. We also know that we really don't need a face bowl, because what we're looking for is, we see the plane of the occlusion as it relates into the condyle, eminence, and so forth. So we see that from a sagittal view, all the different views from a CT scan. If you send one in, if you're really adamant about it, we can still work with it. We'll use it as a validation, but you don't need to do one typically. One thing that's very important, this is really important, because a lot of our patients that we're treating with this type of modality, we already mentioned, they're dentally crippled. They're not your best dental patients. They do have some compromise, be it a compromised occlusion, but many times they have compromised vertical and a loss or collapsed vertical. What you need to be aware of, that before you do your CT scan, you have to, as a clinician, you have to work out and determine that patient's final vertical dimension of occlusion and their occlusion, their MIP, their maximum intercuspation position. So we need the bite and we need the vertical at the time of scanning. The reason for that is that we are going to, even though we're making you a provisional, we are actually kind of going along the lines as this is the final. We are dictating to Dr. Farber where the implants are going to go as far as depth, rotation position, angulation, and all that through our guides. We're going to dictate to you as a restorative clinician as well where the cylinders are going to go, where the prosthesis is going to seat, etc. So we need to have this data worked out. If you don't do this, you're going to have a lot more challenges. It'll work, but you're going to be back to almost doing it conventional, where you have more variables, more modifications, more chair time. So I promise you this, my friends, everything I'm sharing with you, I've done probably 120 plus nSequence full arches. And many of those have been double arch cases. And then prior to that, I've done probably about 60 conventional arches at the laboratory where I would go chairside and do the conversions. And there's no comparison. And when you follow these steps, it may be a little bit more up front, and really it isn't, but it may seem like it if you're not doing it the conventional way and you're making up the day of surgery. We want surgery to be very smooth and minimize the time there for that patient that day. So please know this, that we can open vertical up no more. We don't want to go more than 3 millimeters from what we receive. We'll open a patient no more than 3 millimeters. We say that because we're still comfortable that we can be quite accurate with that. When it goes beyond that, we start running into arc closure issues, other problems and challenges that is just going to end up, you're going to have more adjustments at the time of delivering the prosthesis. And again, we're trying to avoid that for you. We're wanting to make this very predictable for you, make it a good experience for you. And the less time is also more profitability, and the patients appreciate that. They don't want to be there any longer than they have to be. So we do see sometimes if you're going to need to open a patient more than 3 millimeters, go back to what your training has been in this kind of, about locating hinge access, open a vertical, using splints, bite splint therapy. Maybe you have to go 4 or 6 weeks for a patient to determine if they're right, if they can tolerate that vertical. So these are just some things. If you have any other questions about this, feel free to reach out to myself, our laboratory. You're going to get all of our email addresses throughout the presentation here as well. We'll be happy to share more with you. One of the things that we do see happen often is that when you have a patient with terminal dentition, but they're edentulous from the bicuspids back, they do have a collapsed posterior. We need to make sure that you're addressing that and that we're getting the patient stabilized for the CT bite. So again, what I'm saying here is stabilizing the patient for the actual CT scanning. Because a patient, as they're being scanned, and that they have the ability to manipulate their mandible, and if the assistant or whoever's doing the scanning is not watching it close enough, we can get an altered vertical dimension record that way. So what we want to do is to give them something in that area that's going to stabilize them, prevent them, be it bite blocks. Sometimes it could be a hard blue moose bite that's full enough to fill in that area to give them a vertical stop. I'll show a little bit more about that as we move on here. When we look at our bite records, we think about our fully dentulous patients, they really fall into 2 categories. You have the patients that have existing dentures that they're happy with the aesthetics. You're maybe also happy with the vertical. Everyone's happy with what the aesthetics and the vertical of the dentures are, or they're not happy with it, whether it's aesthetics, they have collapsed vertical, etc. Or they may just be edentulous patients that don't have anything as a reference to go by. So if you're happy with your denture, it's nice. We're going to get this denture scan. We're going to talk about scanning coming up in a few slides, but also to duplicate an existing denture. If you want to use a denture as a scanning appliance, there's some alternatives for doing that where you can actually incorporate, I'm going to show you a really neat way of doing it with these scan markers that are basically stickers, but you could incorporate gutta percha, BBs, little glass balls as well, into a prosthesis. But instead of drilling it into a patient's existing denture and placing them, you could actually do a very quick duplication of the denture. Your laboratory, your local labs can walk you through this too. It's very simple to do something like this, to make a very inexpensive duplicate denture, literally chairside. So when we do have a patient that you're going to need to establish their vertical, we're going to make them new dentures. When we get into the bite block stage and you're doing that, make sure that on your bite blocks that you're capturing, we want to make sure you're capturing midlines, but very importantly, throughout the process, is we always want to know the patient's high lip line. This is very, very important for us. The high lip line is not just, when you say to a patient, okay, give me a big smile, that's not going to give you the high lip line necessarily. And the reason I say that is a lot of these patients have been embarrassed about their smile for years. And they actually have ways of smiling to cover that up, cover their hand over their mouth. you want to get them, either tell them a joke, get them a laugh, where they have no resistance to controlling their smile. The reason we want to see this high lip line is that the transition line that we're going to put, our goal is to have that transition line, that is the line between the prosthesis and their natural anatomy, or they come together. We'd like that to be ideally at least 3 millimeters above the high smile line. The reason for that is we don't want a patient to smile and have their lip get caught up on top of their teeth, or if they're from functional or aesthetically as well. So that's also going to help us to know the high smile line is going to help us to know the bone cut, how much bone we're going to reduce. So we'll talk more about that as we move along. Then we're going to get to, set up for try-ins, because we're making sure that, we're going to a final for all practical purposes here with our long-term provisional that will be delivered the day of surgery. Granted, we can make adjustments from that after that day. We have a lot of records already, but we want to be as spot on as possible. So maybe you need to even do a wax try-in for a case. Maybe it's not a full wax setup. Maybe it's bite blocks, and maybe you set up the anterior 6 teeth for the scan. So there's some variables that way as well. But please know, the more information, this is very important, the more information that you give the laboratory, the better we can do for you, so to speak. Our goal, we're greedy. We want as much information as possible, and we do use the information. So again, you could even go as far as maybe fabricating a new set of dentures for the patient, make sure they're comfortable and happy with that, some economy dentures. Laboratories, local labs, or with the mills that can be done. Some of you have even some of your own printers. You can mill even some dentures. We can do that in our lab as well, if that's an option for you. These can become scan appliances and can be modified. I'm going to talk about scanning now, and I think some questions you might have will be answered here in the next few slides. So two topics regarding scanning. It's the intraoral scanning and then the CBCT scanning. Now, when you do your intraoral scanners, you can scan the bite, get the bite for us that way. But do know that even if you have a patient that has terminal dentition and you're scanning the bite, you are still going to need to take a blue mousse bite. And I'm going to explain to you in the next couple of slides why blue mousse and why we need this full arch bite. And a reminder that from this CEO position, if you will, right now, we're comfortable going about 3 millimeters maximum to open vertical, so you don't need to go into a scan appliance or a bite opening jig of some sort if you're within that parameter. One of the things that in scanning about the dosage, high dose, is faster for the patients who move around too much. Some patients they have some scenarios I think of as some Parkinson patients. But the other thing for low dose for patients maybe who have a lot of metal in their mouth. So what we want to share with you is what we found that works the best, and is that the settings on your CT unit, or if you're using a scan center, I think most of you are probably either Dr. Farber, maybe even doing the scans, but at a 0.3 voxel resolution, you can be at a 0.275 is fine. You can be maybe at a 0.4. That's workable. And at a 20 seconds speed, that gives us the information we're looking for. It gives us a detail, yet it's not too large of a file that allows us to manipulate it, and it's easier to send these files back and forth internally at our laboratory. So we find a 0.3 voxel setting to be about the best.
Jeff,
and please go ahead.
I'm sorry to cut you off. Can you go back to the image on the bite rim? There was a question about describing the other markings that you were showing.
Oh, sure. Thank you.
Yeah. And then there was another question about the materials we're using, Pecton or PEEK. Is that for the provisional or the final?
No, that'd be for the final. Pecton's for the final. Our provisional is milled from a PMMA puck, so it's polymethyl methacrylate that is milled from a puck. And then we actually cut back the underside, the integular side. We cut it open and recess it so that we can seat a metal bar inside of that. And then we'll actually we hand pack acrylic to make our long-term provisional. And so our long-term provisionals are actually milled from a PMMA puck, hand finished, packed. The gingival is all packed with acrylic, so it's repairable. You can reline it if need be as well during the integration time. What these marks are here, the midline obviously, is very good to mark a midline. It's just good it gives you a good visual as well. The other marks are the canine marks. Buccal corridors actually don't start at the midpoint of the canine, but you mark the midpoint of the canine, we're typically going to go 3 millimeters back and start creating a buccal corridor. So the lines on the models are showing your midlines. Maxillary model then is showing us those other 2 lines are the canine, height of canine position. So that gives us, also helps us to get a mold to fit within that parameter. Hopefully that answered the question sufficiently.
Thank you.
The field of view, the minimum is 10 by 10 centimeters. We prefer a view of 13 by 13 centimeters and larger if the units can handle that. Once again, the more information, the more data that we can get, the better. By the way, my friends, the scan information, this is all on our website as well. I'm going to show you where this is as we get to the end of submitting these records. Now, something about the blue moose bite. Now, Dr. Farber, I don't know if this is something that you want them to be doing or if this is something that you would do. Whoever's going to take this blue moose bite, what's important to do is that we're going to inject over the clusals of the posterior teeth. This is a patient that has terminal dentition, and it can be for a denture patient as well. So they have their dentures. This could be fine for that as well, because we do want them wearing a blue moose bite, whether to scan, the CT scan, regardless if they have dentures or natural dentition, we want a blue moose bite in there. I'm going to show you that coming up in a couple of slides here. But if you inject in the posterior, have the patient close down and leave the anterior free of material right now, let them close into this position. That way you're able to see for sure that they're getting into the proper position. Then before the blue moose sets, quickly syringe all the way across the luting the posterior sections together, lute that across with the blue moose. So we actually get a full arch blue moose bite. But this is just a little technique for you, because if you load everything up and patient closes down, based on the scenario of the patient, what they have for a definitive bite, they may not get into proper position. So that's why we say, don't put it in the anterior right away when the patient closes. Let them close and then immediately come in and syringe to lock in the anteriors. What we're looking for is this full blue moose bite. And the reason that we want that bite is that a couple of reasons. One, very importantly, is that it's rigid. So we like blue moose versus a bite registration material because the blue moose is rigid, and that way it gives the patient a definitive position during the scan. And a lot of patients, as you know, they're fidgety, and especially elderly patients, sometimes they're trying to make sure they're doing everything right, listen to the assistant, and they're going to realize that they might be moving a little bit, and the assistant may not catch that. So the blue moose actually helps to give the patient a locking position, for lack of a better word or phrase. But here's the other thing it does for us, is that the blue moose, what you see in these the scan here, that is blue moose bite. It's radio opaque. And what it actually gives us is it gives the laboratory not 360 degrees, but about 180 degrees, if you will, of a fiduciary reference point or fiduciary marker that we can go in and validate from analog data, physical blue moose, or look at the scans. We can pick up information and data. So we're one of the few. I mean, this is the technology that we've developed and that we know works. And a lot of labs have no clue why we're even talking about this, and they don't understand the rationale for it. So this kind of technology, a lot of labs are jumping on board because they can make it look like it's simple and they're doing the same thing we're doing. But I promise you that a lot of them are not nowhere near getting into the detail and the depth that we're doing. So now we're getting ready to scan. So we've made the Blue Moose bite. We may have the dentures in place. Maybe that's bite blocks with Blue Moose bite, a combination of things. The one thing that we do not want you to use is we do not want to have the patient biting into the bite fork. They are to be closed into the bite, the Blue Moose bite. If they have natural dentition, we still want a Blue Moose bite, please. Now, close, use the chin rest. Just have them sit on the chin rest, and then that's how you're going to want to do your scan.
So
Markers.
to answer your question, sometimes I get the scan sent to me already. Some of my restorative doctors are using their own scans, which is fine. And other times we're doing it in the office. Now that Blue Moose, it's radio opaque. So does that block out? Is it too much sometimes in the posterior that may affect the planning at all, or no?
No, we've been using it for years. Actually, we got a patent on it.
Okay.
Yeah, no, it works out real fine. Because what we're going to do too, I'm going to show you, we're going to scan the denture as well.
Mm-hmm.
And as far as for dentures, we get everything that we need.
Okay.
Radiographic markers, I'm going to show you something on 2 slides coming up. I think that's going to be very useful for everyone. But even in our posteriors like this, if we're doing bite blocks, the Blue Moose is in place, we want to get some markers in here. Radiographic markers, whether the BBs or I'm going to show you the Sure Mark, they're stickers. We need to have these, we triangulate, let me go next slide. Oops, sorry, I hit the wrong button, my bad. We're looking to triangulate. So if you look at the palatal view here of this denture, when you're placing these markers I'm showing you here on the left, they're called Sure Mark. They're scan markers that are one-time use. You get them on a sheet of stickers. If you think of the Breathe Right that go on the nose, they're shaped like that. They don't act like that, but they're kind of shaped like that, and they make them for centrals, laterals, canines, bis, and molars. And if you look at the radiographic image here on the left, that little white line, that fine line, that's the marker for that. It shows the lab exactly where the facial, incisal, and lingual palatal of that anterior tooth is, whichever tooth you put that marker on. So that gives us a wonderful relationship. Look how accurate and how much information we have here with that. So I'm going to give you the website coming up on the next slide. So if you want, get ready. You could take your camera and take a shot of the screen or write it down. I got the link all set up for you on the next slide. But what we're looking for is we find that 7 markers are probably the best. At palatally or lingually, if you place 3 of them and kind of triangulate it, whether it's a central, a lateral, or canine, somewhere in this area, and then somewhere in the first molar area, something like this. So lingually or palatally, we want to triangulate. Buccally, then, what we're looking for is to just kind of spread them across the arch, maybe 2 on the posterior quadrant, 2 in the anterior area, maybe 2 then, space them in between your triangulated ones. So we'd have a buccal one out here, just space them out. Is all we're trying to do is get spacing. Don't want to put them right opposing another one. But if we get 4 on the outside, we get our corners of the arch marked and these triangulation, that gives us the data. And what that's doing is allowing us to line up one arch from another arch. And it helps us to line up all of our planning, our software. This is the website.
Sorry, Jeff, there was a question about 7 markers per arch. You would alternate buccal, lingual in that pattern that Jeff described.
Without them being opposing each other. You wouldn't want to put one right opposite, like here. If this one's right in between 11 and 12, I'm sorry, 10 and 11, you wouldn't want to put one right next to that, move it over here, and just kind of give another mark here. So you're kind of connecting, we're going to connect the dots, for lack of a better way of saying it. I hope that helps. I love these questions. Thank you all. This is the website, suremark.com/catalog/dentalmark. That literally takes you to this page right here. But if you just go to suremark.com and you want to go to, it's what it says here in the red circle is dental mark. That, because they also do markers for breast scanning, brain scan, and they do them all for the medical world. But so you don't have to get stuck on their website. If you go to Suremark and just even do dental, but here is, they come in a box. There's a variety of options, but I think you'll find these to be very user-friendly for sure. We like them. They're easy for you to use. They give us a lot of good information. So that's something to think about. And here's another look at it. So when you're going to have a denture patient, what we're doing is we want this denture to be scanned. So not only scan the patient with the blue moose bite in place on the chin rest, scanning the patient, you're going to take the denture out and you're going to scan the, this is for the working arch, you're going to scan the denture. If the patient needs a reline on the denture, you have two options, because we want to have a very nice fitting, we want to capture that anatomy very nicely off of the denture. You can either do a wash impression, PBS material. Most of it is pretty radio opaque. If you're going to do a lot of these cases, there's actually Heraeus makes an impression material, and you can even check it with your Patterson or whoever you're distributing with. There's actually radio opaque impression material that's works. It still has all the accuracy, but it's radio opaque. That's very nice as well. Or you could do a reline on it. But we do find that MucoSoft, even if you did a soft reline, just a chairside reline with MucoSoft, it'll come up somewhat radio opaque, and so you can capture the actual anatomy without having to spend the money in doing a reline on a denture. So I hope that makes sense, that what we're looking for when you're scanning this denture is another aspect of the anatomy. We are validating so many different points. We have 5 reference points of validation that are proprietary to us. That's what makes our system, I think, as successful as it is. Here's some of our actual scans that we've received that have been problems. And one thing we find out a lot of times is that the clinician's not even looking at the scan before they're sent. They're letting the assistant do it, and they're not even checking them. And it's not to say they're not qualified to do it, but too often, if the assistants don't really know what is a good scan, a lot of times we get them where there was maybe some movement, or the setting was too fast. The one on the left is there was too much scatter because of metal. So we're just encouraging you, because all this does is takes more time. When we call you up, it takes us about 2 to 3 days once you receive your information to go into detail with your scans to start doing what we call segmenting. We're going to go 1 millimeter slices through your scan, which to my knowledge, we're the only company doing that to get that kind of accuracy. I will share this with you. If you have a concern about a scan that you took and you're not sure if it's good enough, don't let the patient leave. Call the laboratory, nSequence Lab, and tell them that you want to send us a scan right away, and we will do an immediate cursory overview. It's just a validation. We won't treatment plan the case, but what we do is we'll tell you if the scan is going to work. Because the worst thing to do is have a patient leave and then have to come back again because something wasn't right. So within 10 to 15 minutes, we'll be able to evaluate your scan and tell you if you need a new one or not. So please keep that in mind, because too often we have to break your hearts and tell you that the scan isn't any good. So please keep that in mind. Might as well pause here for just a moment on scanning, because I'm going to get into patient photos, and then we're going to get into submissions next. So is there any specific questions that you're getting on scans?
I don't see any questions coming
Okay,
through.
great.
I think we're good.
We're going to have some Q&A as well. So if you guys want, write them down and we'll get them. Okay, photos. Now, these can be done with your cell phone. That's fine. But we do want some specific, and again, on our website, we detail this out in more detail. But what we're looking for is minimum of 5 views. And again, this big smile is where we want to get that high lip line as well when you have the natural dentition. We do like to get a retracted one. When we get a visual like a number 2 there, when we get a photo like that, And notice the framing of the head. We're not seeing 2 feet above the patient from across the room, and you're not, right up into their face. We like to see getting the eyes in the photo. We like to see the chin. Really framed like this is what we're looking for. That gives us, when we're doing our smile design, we take a lot of things into consideration, golden proportion. We want to look at, making things symmetric as well. So this is important. That number 2 is a very important photograph, and a lot of times we don't get that. Number 3 is we're getting that low lip line, that rest position. This is important for us to have because when we know what the length of the tooth is and we look at the patient that we're going to be constructing a provisional for, that even if you're doing a setup for a wax setup, let's say if that was for an elderly patient, we want to know where the relaxed lip line is, because as you know, it's more natural for a woman to show maybe 1 to 2 millimeters of tooth based on age, versus a man sometimes when they just part, they really don't show any. The older you get, muscle tone, facial mass drops, that changes. But these photos help us to give you a very nice, very natural looking long-term provisional for the day of surgery. In the left profile, right profile, we're looking for exactly that. We're looking for overjet, overbite. We're looking for flare, inclinations, and so forth. So these 5 photos are very important to have. And don't be shy. Take more photos. When in doubt, take more, but make sure you've covered your bases on those 5 photos, please. Photos of their existing dentition in the mouth. Even though we're not going to replicate it, it's nice to see in the laboratory. I mentioned we're greedy. We like to get as much information. We have reference points. You could even say, the existing partial, there was too much overjet. There wasn't enough overjet. Well, now we can look to see what you're referring to. Visual. A lot of visual reference points just help us to make things better for you and for your patient.
Jeff, I just want to point out that these are very easy to find on the website. So a lot of times in front of the patient, my assistants will just do the drop down on the site. We should show them later where it is.
I'm getting to that. Yep, you bet. I'm going to show you exactly how to get all this. Here we go, right here. Perfect segue. Thank you, Dr. Farber. So now you've collected your data. We've got our 5 pieces of information. Now what are you going to do with it? So now, based upon who's filling out the form, but there's 6 steps to submitting a case. It's going to be your form, photos, the scans, then the uploading everything. Then you're going to get a shipping label and schedule a pickup with FedEx. Okay, here's how that works. This very straightforward. We just updated this as a couple of weeks ago even. So you go to our homepage, nsequence.com, and wherever when you get to our homepage, you see at the top of the page a couple places that says send a case. Anywhere on our website, if you're scanning through, looking at different things, because we have a lot of information there, you see this word send a case. You click on that, it's going to take you, the right side of the screen is just a continuation cascade of the left side. I just can't fit it on one slide. But there's your 6 steps right there. And so what I'm going to show you is the first thing I'm going to do is complete the RX form. So I'm doing a guided prosthetics. I'm going to click on that. So when I click on this right here, so I click on that, and that's going to take you to this page. There's your online digital RX form. Once you filled one out, then it starts having an autofill for your future cases as far as your address and things like that. So yes.
A lot of times when we're collaborating on these cases together, a lot of times my office is filling this out, but then putting in the restorative doctor's information to contact them for the shade and so forth. And so that's how we've been doing it.
Okay. And I would say that if it's simple things like shade, restorative doctors, share that with them. Because here's what happens many times. We'll get the information, and Dr. Farber's team, they're great about it. They get the patients there, they'll get their information, and they're ready to send it to us, and we're ready to rock and roll. Problem is, we cannot start a case until all the data is there. We cannot go kind of hodgepodge things and just put little pieces together, come back and we'll catch that later. We need all the data there because all the data relates to another. A shade's not such the issue, but not having the hard blue moose bite if you were sending that in, you know, things like that. So if we're relying on you to get study models, restorative doctors, if we're relying on you to get study models, you've got to be prompt. If Dr. Farber's team's reaching out to you, you need to be prompt in finishing that information and getting it to us or back to them, because it'll delay the case.
Okay. We have a question.
Yeah.
Yep.
Can we?
I'm gonna unmute.
Glenn,
Yeah.
well, you have a question?
Yes, I did. The backup denture.
Yeah.
I mean, Jeff, I've assisted Dr. Farber in a few cases. Fortunately, you've never had a problem during surgery where the long-term provisional has not gone in or you haven't delivered it.
Yeah.
I mean, I suppose it's possible you wouldn't know, even if you know, do all your due diligence before the patient's actually scheduled for surgery. How necessary is it to have them? And when do people opt to purchase the backup denture?
You know, here's the thing. I can tell you that all the surgeries I've done, there's only been a handful that we've needed to go to the denture. A lot's on that person on the other side of the screen here, Dr. Farber's clinical skills. You know, the good news is it's usually not a surprise on bone density. If you have a patient, we're looking at our scans and this is a, you know, D5 bone, let's say, but I've had cases literally that were 6 implants in the maxillary. A lot of it was D4 bone. The surgeon did even do some undersizing based on the implant design. Nowadays, we've got better, more aggressive threaded implants that help for that.
Right.
I say that there's a lot of clinical things that can help you to decide if it's really necessary or not. I look at the implant system, while also the surgical experience. I mean, Dr. Farber has done 1 or 2 implant cases in his career, so he's got that tactile feel for that. He knows what he needs to do with that case. But even then, he can be faced with things that you get in there and, wow, we can't load the case. Especially if we don't get a terminal implant that would get good stability on terminal implant. Many times we can just cut the cantilever off of the long-term provisional. Patients are still happy. If they're missing a second buy and back, they're still happy with that versus a denture. So we've done that many times. But I can tell you this, if you need a denture, you do the day of surgery and you find out you can't load the case for whatever reason. Sometimes it happens a medical reason. He has to bail out of the procedure before finishing it, and he gets the implants in, but we got to close. You don't know when that's going to happen. Medically compromised patients.
Right.
It takes us about 3 to 5 days. We can get you a denture in about 3 days. We're using our carbon printer now, so we can turn them pretty quick. But just put yourself in that patient situation. If they don't have teeth, you have to look at that too. Are they home? You know, they're home-based person. They're retired. It's not a big deal if they go without teeth for a few days. Some people may want them to not have anything on it for a few days. So I don't know if that answers it. There's not a real straight, flat answer to that. Dr. Farber, your thoughts, please.
Thank you. So Len and the rest of you, usually when I'm planning the case out, so a lot of you on here today have done cases with me, but for those of you who've not, we set up a meeting, myself, the restorative doctor, and the lab. And when I'm going through the case with the lab tech, the 3 of us, and we're looking at bone density and all these other factors that Jeff mentioned, that's where we kind of make a decision. You know what? I'm a little concerned about this case, or there's other issues. That's when we make the decision. Let's play it really safe. Let's have a backup denture. And in the last 5 years, I think I've ordered 2. And fortunately, I haven't had to use them because there's been situations where, like Jeff said, I cut the provisional shorter because we weren't getting good torque in some of the implants or something like that. So it's really it's a few $100 decision to make. Do I want to spend $300 or $325?
$325, yeah.
Yeah. So we make that decision right then when we're planning it. And if not, like Jeff said, worst scenario is we get one in 3 days. So it's not terrible for us anyway. The patient may look at it differently.
Yeah. Thank you.
Yeah, great questions. Thank you guys for the questions. Really appreciate it. Okay, so photos. when you see on our website, again, I just did screen captures of the website. You'll see these underlined areas. That's where you click on it, and they'll give you more detail about what we're needing. That breaks down, and it tells you here in scriptive, a little bit more what we're looking for, why we're looking for it. CT scans, some of the things I showed you, you can click on any one of these scenarios here, and you're going to get, from that, you're going to get these PDFs. These are actually 2-page PDFs, front and back, that will give you very specific detail. So it's all there on the website, and it's just, send a case and start clicking away, and you're going to find everything for you right there. How to upload your files. Here's where you click here for the uploading. Digital impressions. Dr. Farber, I think you mentioned about the iOS scanners. So the left here, this is what you get, the pop-up to submit the folder, to send your DICOM file, to upload your files. The one here on the right. Now here's our 2, 4, 6. Yeah, there's 2, 4. There's 6 of the most common ones. You click on that, the name, then there'll be another drop down that'll give you some little more tips and pearls there. So we've got a lot of good information for you. Then from there, you'll see number 5. Click on that. You fill out your shipping label, and then you generate the label right there. You print it yourself. Then you click on there, and you can set up your pickup from FedEx. So right online, you can do all the things you need to do. There's your FedEx label, and things are up and running and on the way to nSequence Laboratory. So that's kind of the last of my slides to go from the digital analog records, and we're going to get into finals next. But Dr. Farber, anything, summary points that you'd like to make about this and how you want to work with them and coordinate with their offices on records?
First of all, thanks for running exactly on time. Wow, did that in under an hour. So we're going to spend another 30 minutes on going a little bit on coordination with charging patients cost and the prosthetic option. But as far as this goes, we've been working this out pretty well. I think the one thing is, on my end, if I could, which I'm going to work on, is just getting more coordination to let them know when we're doing the scan so they can get the models. A lot of times the way I see it happening is the impressions and the bite are taken after we do the scan. Maybe we can, again, sometimes the patient hasn't really bought into this yet. So that's why they're coming to my office. If there's a way to, before you even send them to my office, get them to agree to this treatment, then we can get those records done. It might save a little time of back and forth, maybe another appointment. And we could all work that out one-on-one. I know I've been working with Leslie on phase 2 of a lunch and learn with scripts. So maybe, if we can all get together non-virtually or maybe virtually have some team meetings, we can work that out. But that's really all I have to say as far as records. It's been, if there's questions now to the rest of you here, this is as far as records go. Any questions at all? Raise your hand and we'll unmute you or write it in the chat. We do have a hand up. Okay, Len?
Yeah, hi. Jeff, I've been looking at a Plan Mecca 3D scanner to purchase. One of the selling points on that system is this anti-shake capability for persons, for children, anyone, to minimize the scatter and blurriness noise in the scans.
Yes.
That company is also advocating ultra low dose radiation, and they have some sort of complicated software that with low radiation, but yet the same number of images, or they're not compromising on the number of voxels according to them.
Okay.
But the radiation total radiation dose is lower. You mentioned something earlier about, if the scan's not looking great, you're going through millimeter by millimeter. With something where there's that kind of a scan, do you think that that might be an issue? Like that post scan, if you go to manipulate the image there, that you'll start having an issue with something that's compared to something that has a higher radiation dose?
Dr. Fazio, I don't think so. I'm not an expert on the scanning part of it, quite honestly. But I do know that the technology, that how it has developed, and for a brand new unit, it is, I have a friend that works with another company, and you know, talking with them, they seem to have worked out a lot of those issues. So you know, for us going a millimeter by millimeter, what it's really doing is we're doing that to find whether it's artifacts or inconsistencies, because for us it's about connecting the dots, because we're making our foundation guide is going to fit buccally as well as lingually or palatally onto the bone. So we're looking to get as much information as possible. I don't think there's going to be any issues. You know, I don't think there'll be any concerns. I mean, I know Plan Mecca is one of them that we do get a lot of. I do know we get a lot of scans from people using Plan Mecca.
Okay, thank you.
Yeah, thank you. Okay.
Any other
Anything else?
questions? And that will move on to the second part. I think we're good. Okay.
Cool. Hey guys, I'm having fun. I like doing this. This is kind of I've been lecturing for 25 years or something, and it was hard. Started 2 weeks ago doing these virtual ones, and I didn't know where to look, and it seems weird to do this, but I'm looking at Dr. Farber there. He's looking good in his background, and this is kind of cool. So anyway, sorry about that.
As far as cone beam scanners go, I would really, you know, very carefully look at the sharpness of the image, what they're showing you. And my machine, there's a lot of machines out there now, and there's no really good resource to compare machines as far as I know. So you really have to look at the image quality and really look at the settings, because sometimes what they show you is at a different setting. Most machines you can range your settings. So if you're doing a full arch case like this, you can, you know, you may have to increase your dosage. Again, the field of view, you know, originally I added the original classic iCat. We could get a full image of the whole head. You don't really need that anymore. So if you're cutting that image, you're lowering the radiation. Depending on what we're looking for, that's where you have to change your settings. So you take some time and look into the different options. A lot of us here in this group have machines, and we can talk another time about, you know, who likes what machine.
Thank you for that. And the other thing too is, you know, we get a new machine, Dr. Fazio, feel free. I mean, do a scan, you know, and send it in the lab and have them say, hey, how's this looking for you guys? What do you think of this setting I'm at? So before you get an actual case, you know, something you could work out. We'd be happy to do that for you. Okay, well, we're going to get on to the next step, which we're going to talk about. And this is a good topic, because the definitive prosthesis, the finals, the patient's going to come out with a very nice, you know, long-term provisional. It looks very nice, and you know, we've got you know, metal reinforcement in them. Their patients are just, you know, usually quite happy with that. But we still got to look at, we're going to come into the finals. What are we going to give this patient now as the final? To get to the final, so let's stop for a moment here. Where we're at right now, you've had the day of surgeries taking place. That may have been 4, 5, 6 months, whatever Dr. Farber's protocol is on integration time. Where we're at right now, what I'm going to share with you is, what are we going to do? Because this is not just the, this is what are you going to do for the final. This isn't just talking about the prosthesis. This is how you're going to get to that final prosthesis. Because of the technology that we utilize and the techniques that we utilize, we're able to go from, you know, as many as, you know, 7, 8, 9, even more appointments sometimes to do a final conventional all-on X, where the patient is, you know, you have to do open tray impressions and so forth, to 3 appointments, as few as, well, actually you could do as few as 2 appointments if you didn't want to do a try-in. But what I wanted to share with you is that part of those of you that have not worked with nSequence and worked with Dr. Farber doing one of these cases, what we're able to do, how we're able to eliminate several appointments for you as a restorative doctor, which that's very important, because if you can get a set fee and have 3 1-hour appointments instead of 6, 7, 8, whatever 1-hour appointments, or a couple of might be a half-hour appointments, some maybe even longer. That's all about better profitability. And this is going to be very important, even more so than ever, I think, is being as profitable as you can. So the way we're able to do that is something called a clear duplicate bridge, which at the day of surgery, Dr. Farber picks this up the day of surgery. It's a replica of what the patient is leaving with, just showing the anteglo view of it here. But this is going to give us the ability to eliminate these appointments for you as a restorative clinician. Here's how this works. So I'm going to back you up for just a second. So at the day of surgery, Dr. Farber was able to place what we call, we give a second set of these temporary copings. There's one set that's going to be luted into the provisional. This second set is going to be luted into this clear bridge. So he's just completed luting the provisional into place. This is day of surgery. That's come out of the mouth. Now, typically, what the next step would be to close, graft and close. What we're going to ask him to do is one more step. That's going to take him another 10, 15 minutes. But this, for you as a restorative doctor, this is huge for you. This is going to save you all those appointments. Simplify the fabrication of a final prosthesis for a full arch rehabilitation, to where you're doing really nothing more than unscrewing a prosthesis. And I tell you, I went through all the nathological courses years ago, with the Niles Goucher, going way back. And we don't have to go down that path with this kind of technology. So what I'm going to share with you next, he did do this on the far right. Day of surgery, we've captured, this is like a verification jig. It's a bite block. It's a final impression. It's going to be an aesthetic try-in and all that for your first appointment. So this was done the day of surgery. The reason I'm emphasizing that it's the day of surgery is there's an occasion, and according to our lab, the statistics that we have, the numbers that we have, about 20% of the cases, the day of surgery, the clear duplicate bridge was not what we call picked up or luted to, the cylinders luted to the clear duplicate bridge, giving us all that information I just mentioned. That occurs most often, well, I shouldn't say most often. It occurs 2 primary reasons. One, it could be a patient, because we do have medically compromised patients at times, that the anesthesia, they just want to get them out of anesthesia, and another 15 minutes, they're coming out. And they don't do it that time. Other times we find is that the surgeons weren't aware of the value of what a clear duplicate does for you as a restorative doctor. Lack of knowing what technology and what our system is about is a cause of it. So here's what I want to share with you. Dr. Farber's picked up the clear duplicate bridge the day of surgery. This has just been sent to you. It's been sitting there for 4 or 5 months. Now you're going to see the patient for the first restorative appointment. I'm sorry. So this is what, when you're not picked up, there's another protocol we're going to talk about next. But here we go. I'm sorry. I added some slides in, and this was one. There's 3 scenarios for your first restorative appointment. A first restorative appointment. You're either going to have a clear duplicate bridge that he did pick up the day of surgery, which I just kind of showed you and talked about that. The other option or other scenario is that it was not picked up the day of surgery, and the patient presents to you to start the final prosthesis, so your first restorative appointment, and you're seeing a gap here. I have photos I'm going to show you, but you're seeing a gap. There's been a lot of bone healing, bone remodeling, tissue remodeling, and now there's a gap there. But the clear bridge is just a bridge without any cylinders. The other option or scenario, I apologize, the word I want to use is scenario, is that their clear dupe does not, the provisional, the patient presents and there's really no gap. There might be a little just on the transition line, again, I'm going to show you this when I get to those slides talking about that. So I'll get back to that. I want to show you a visual of it. So this is, bridge was picked up probably, you know, almost all the times. What I'm going to show you the next few slides is what you're going to do for your first, typically 1 hour appointment. Patient, you've probably seen the patient a couple times to adjust the occlusion, maybe check their home care during that integration period. So here you go, first step, you're going to remove the provisional, utilizing your driver, remove the provisional. The clear duplicate bridge then has been sitting now, like I say, for several months. It's a good idea, and I highly recommend you do this, is to take just an acrylic burr and just go in here and grind. Don't be real finesse about it, and create at least about another 1 to 2 millimeters of gap. 2 millimeters is a good gap to create. Just grind some of this integrous tissue away, because what we're going to do is we're going to seat this and we're going to take an impression underneath that and get your final impression. So you remove the long-term provisional, you've taken the clear bridge, you make these, you relieve the area on the integral side, you would apply some tray adhesive into here, all right? Now you're going to seat this, finger pressure with your tightening your screws, the little prosthetic screws. They'll be with the bridge in a little crown box. And it's a good idea to take a radiograph just to make sure that everything is seated. I have not yet seen one, not to say there isn't, because I don't see every case we do. But day of surgery, Dr. Farber especially is so experienced with doing these type of cases. He's going to make sure all your components are down. Because we have a metal bar in the prosthesis, we don't see migration of these implants during the integration time. So pretty much things are the way they were at surgery, here 4 or 5, 6 months later for you, which is a good idea. There's your verification jig. Now, let's say if you had an issue, I got to watch my time a little bit because I want to talk about some of the money.
And Jeff, we have a question too.
Yeah, go ahead.
It was about troubles with the nSequence protocol as far as ridge reduction, implant placement, delivery of fixed. I just wanted a little more elaboration. Let me unmute.
That there was troubles. Oh, why we'd have to go to why we would not pick up the clear duplicate? I guess I'm not getting the question exactly.
I think the question is more surgical than in the restorative end. Let me just interject one thing here. For those of you who there are some people here that I have not done cases that I invited in, and they may not have seen the whole nSequence protocol. So we didn't go through that today. That was not the point of the meeting. So for those of you who want to see the whole nSequence protocol, you can speak to me or Leslie. We could set up time for that. This is really just the restorative end of it at the end of the healing from the integration. But Peter has a question. I don't know if you want to talk about it. Peter's one of my surgery friends in LA, and he had some more surgical end questions. I don't know if you want to do that now, Peter, or another time. Up to you.
Whenever
if we
you
could
think
take
it's
it,
best, Alan.
Dr. Moy. Hey, Dr.
Hi.
Moy.
Hello.
If it's a quick question, just because we wanted to wrap up by 3:30, and we have so if you could talk as fast as us New Yorkers, you can go. Okay.
No, go ahead and wrap up.
Okay.
Okay.
Okay. We can
Dr.
touch
Moore.
base in the lecture.
Yeah. Well, I'm not cutting off afterwards, so I want to be respectful of everyone's time.
Okay.
So you got the clear bridge in. Now you're making an aesthetic evaluation, and treat this like your wax setup. I mean, you talk to the patient. Were they happy with their provisional? Do you want to change anything? You can grind on this. You can add to it. You can change the mold. We can change shape. This is a try-in. So you're getting your try-in out of the way right here. And then you're going to adjust the occlusion, very importantly, because you probably adjusted the bite a few times since the day of surgery, or even at the day of surgery, maybe some adjustments. So we want to capture all the modifications here. Take a new blue moose bite. Now this doesn't have to be blue moose here. You could do any type of bite registration material, but you capture a bite. If you grind on the opposing, take a new PVS impression or scan that opposing if you adjust the opposing. We're making the final prosthesis next, right? So we're going to a try-in, but we're on that track. So you haven't taken the clear bridge out. It's still in there. And what you're going to do, because we've created a gap, you're going to take some light body PVS and you're going to syringe it from the buccal all the way out through the palatal or lingual. And you're going to capture this healed tissue, the transition line. Do not end up like this. We want to get all of it. Again, we're greedy at the lab. We want to see all this because we want to make a beautiful transition line for you and make it as hygienic as possible. You're going to take an impression. Then you're going to remove the clear bridge. So we've done a bite adjustment, aesthetic evaluation, verified it with an X-ray, you're taking your impression, and now you're going to take that out, replace the provisional, and then you're going to send to the laboratory. This is what you're sending to us. There's your final impression. It's been adjusted, your new bite. These are the items you're going to send to us. And again, we have all this listed on the website as well. Now, what I need to go through here, and I'm not going to spend too much time on this, quite honestly. We have a PDF of it, and this is not, because of the sake of time, this only happens a few times. And Dr. Farber, knowing your experience with this, I mean, we can go into this, or maybe I'll pick up on another time, but I want to go through it, is that if the bridge wasn't picked up, and here's that gap that we see. Patients showed up, and they have a big gap here, bone remodeling, tissue remodeling. We're going to need to figure out how do you relate that clear duplicate bridge to the mouth so that the restorative doctor, on their first restorative appointment, can lute the temporary cylinders to that clear bridge so that we don't have to have open tray impressions, bite block impressions, and so on and so forth. The other scenario is, maybe that patient didn't have a lot of bone remodeling or wasn't a lot of bone reduction needed, and it's pretty darn good, and it's making contact. So there's no gap or no space there. When there is a gap, we need to create a seating jig or like a positioning jig or a gasket. And so before you remove that, you would just shoot some light body impression material all around this, and then you remove the provisional, and all we really create is like a little tissue gasket. So Dr. Farber, we're making a modified tissue gasket is kind of what we're doing here. The clear bridge could set into that, just kind of try it and go, yeah, all right, that fits in that pretty good. Then you're going to put your temporary cylinders on. These will be included with your kit. You're going to slip that little gasket over those, and then you're going to put the clear bridge, seat that into that, close the patient into occlusion. So this impression material, that gasket, is acting as a guide to get the clear dupe in the right position. And so now we're going to have the occlusion, just kind of hold them gently into position. Then you can lute from the buccal, those little, we have access holes here. You can inject from the buccal, maybe just do 2 at a time to stabilize it and come back, and you can backfill from the occlusal. And the other scenario is where there is no gap, then it's pretty straightforward. You can just put the cylinders on, you put the clear bridge on. We like to mark it with Sharpie to see the holes, a little bit easier. Close the patient down, inject from the buccal. Again, it's just, letting the patient occlusion dictate it. Now what you've done in either scenario, you've luted the bridge, the clear bridge, to the temporary cylinders. So now you're just going to do the same thing you did before, is create some gaps. So take it out, create a gap, and then now you're just going to take a bite, and you're going to take a final impression because we created a gap. What you did before with the impression material was not an impression. That was just a jig to position it. So we still need to get our final impression. Again, my friends, that doesn't happen very often, the other scenarios I just showed you. So I just wanted to show you another way around this. Okay, now we're going to get into our finals, and I'll take questions on everything at that point.
Jeff, before you go on,
Yes,
one thing I've noticed, and maybe you could, sometimes the midlight is slightly off. So how do you want that indicated on the clear bridge? What's the
great one. On the clear bridge, mark it. Okay. Either mark it on the clear bridge, just go ahead and literally mark it on the clear bridge, take a marker and put where you want it, or at least note it and say because we have a midline here, we know where it is. If you don't like it, say go, move the midline toward, I move the midline to the mesial 1 millimeter, 2 millimeters, whatever it is. So either mark it or for sure, I still mark it and also communicate it.
Okay.
A picture wouldn't hurt either.
Oh yeah, yeah, market photos. Those pictures again, it's nice to get any pictures at all. So you've sent that to our laboratory. What we're going to send you back then is we're going to send you a full setup with a screw retain base plate, if you will. So you're going to remove the provisional, screw the try-in in, wax try-in, and just do a standard evaluation of the try-in. Send it to, make any changes. It's a standard try-in. Make any changes you'd like, send it to us. Your third and final appointment should be delivery. You'll get the final, remove the provisional, and deliver the final. And do your normal things that you do for a final prosthesis. So we'll finalize the last couple of slides, just talk a little bit about the cost, or fees, I should say. Dr. Farber, I'm gonna let you, I know you've had conversation with your doctors, but if you want to address this slide, and then we'll just kind of go from there.
Okay, to save time, I'm going to go through this pretty quickly, but feel free to reach out to me. We could meet one-on-one. So most of you that I've done these cases with, we've already had a meeting and we've decided on what the case fee is going to be, whether it's 25, 30, 35,000, whatever we've agreed on. Make sure that if you present the fee or I present it, that we stick to our original fee. And I'd like to make it a little higher. We're going to talk about why now with the new prosthetic options. The key here is that when you present the fee, make sure my office knows that and vice versa. So we run into that where they jump and get to your office before I've even notified your office that we had the consult. So we're trying to make our office has templated a contract with the patient, which shows your fees and the case fee, total case fee. And that's regardless of 4, 5, or 6 implants. We're tending to go to the nano ceramic material in that fee. And the key though is that we cannot collect your payment. So what we tell the patient is that you're going to make direct payments to Dr. So-and-so restorative office. Make sure that when we tell you that we've had the consult and vice versa, you make those payment arrangements. In New York, we can't split fees. So Care Credit can and Green Sky can. The key here is that one is that we've communicated well with each other so the patient doesn't say, oh, Farber said if you prepay it, we get 10% off. We don't do that with these kind of cases. We consider these already a reduced fee case. So be careful of that because patients, believe it or not, they lie. Maybe just to me, but you know how that can go. So as far as collection goes, you're going to collect your fee. Most of you, we've worked out what you want your fee to be. And then some of you want certain companies presented. I know there's some that want to work with a certain bank, as well as some want to work with Care Credit and so forth. That's fine. So let's meet one-on-one with that. And we've been really tweaking our system in our office. And you're welcome to have a copy of our so-called contract with the patient so you can present it the same way. So if you present it and the patient signs it, scan it and email it over to our office or fax it to our office so we both have the same agreement. That's really the key, so the patient knows we're communicating with one another. Any questions? I went through that pretty fast. A lot of you we've met about that. I want to spend the last few minutes on restorative options, but I'm open for questions about this fee thing. And Len has his hand up. Len.
Not so much a question, Alan, but just a comment to make about that. The contract.
Okay.
I just want to tell the group that, Alan, you remember we had that one patient who did not want to complete treatment after the surgery. Mm-hmm. And it was, thank goodness for your contract and how clear it was that there was a certain amount of money due to me and a certain amount of money due to you, that when the mother of that patient who was paying decided she didn't want to pay anybody because the son didn't want to go forward, I was able to recover after she put a stop payment or requested that the charges she had already made to me be reversed to her. Of course, the bank complied with that, and then all of a sudden, I know I get quite a large deduction from my account. Well, that contract saved me, being able to prove that to the bank that, you know, this person signed on and was contracted to complete this, and that money was not refundable.
Thanks. So yeah, that's a good. Thanks for bringing that up. So this was a somewhat mentally challenged patient, and he didn't want to come back for the final. So and that's a good point. So whatever financial arrangements you make, don't, make sure you get more than half, or make sure, I mean, I cover the lab end, that's where we've been working it out. So really it's your time, so you're going to have less time spent if you don't go to final, but still you want to cover your time planning this case. So some people really like that provisional also, and may not come back for that final. So you want to make sure you've got whatever percentage of that case fee in hand when we go to do that case. So 2 points out of that. So I'm glad that my so-called contract worked out with credit card companies.
Yeah, for sure.
To know.
Okay.
Let's wrap this up. Okay.
Okay. So this is our fee just for the final prosthesis for what we call a DTA, denture tooth acrylic with a titanium bar. And and then zirconia is another option. It's $3,500 without any cutbacks. We can do 6 anterior cutbacks. We add about a little more than it's like $560 for cutbacks. This is what we're seeing most people are doing. I believe, Dr. Farber, this is what you're kind of leaning toward, is the nanoceramic. To me, hands down, this is the way to be going. Restorative doctors, this is the way. I mean, I think it's wonderful that you're doing this, Dr. Farber, because it costs a little bit more than it's about $1,200 more price. But for you as a restorative dentist, teeth break off these denture hybrids. They just do. Every time that tooth breaks off, the patient comes back, that you're losing profits, costing you money. Patients get a little worried about, why does this happen? Did you do the right job or not? So the nanoceramic, and then a high-end one that we have is a pecton, which is actually 12 individual lithium disilicate, call it EMAX crowns, or you can have zirconia. You can have anteriors, they're individual crowns on a frame of pecton material. I would be happy to email someone more information on the pecton if you'd like it. I just want to quickly tell you, those of you that worked with nanoceramic, what it really is. Nanoceramic, the understructure, instead of a titanium bar, it is a polymethyl methacrylate that is impregnated with nanoceramics, but it's done in such a way that I call it like a dental Kevlar, where the way the material is fabricated, it's more of a web-like, mesh-like, if you will. So we'll design that, mill it, then we scan that, and then what you see here in the bottom left, we mill the nanoceramic, the teeth and the understructure for the soft tissue are milled from a puck of nanoceramic. So we mill that, then at the laboratory, we're going to bond the nanoceramic teeth and frame to the triloar understructure. And what the benefit to the triloar, then what you see the pink is Gradia is a light-cure composite. We'll use either Gradia or Axiom is another material that we use. And then there's an OptiGlaze over everything. This is repairable. If a tooth did fracture, chip off a tooth, you can use any composite material you have in your office and you can just treat it like a resin composite. You can add to it. There's a little bit of flexure to it, more macroly, so it's better, it's kinder to the whole system as far as load distribution. Zirconia is very hard to the button to implant interface, to the implant to bone interface. This has a little bit of a cushion to it, if you will. You can't feel it flex, but it does have a little bit of modular elasticity. So I think, hats off to you, Dr. Farber, for just kind of making that kind of the standard for your doctors, because it's a benefit to you all that he's doing that. So I'll finish with that. I ran a few minutes over. I apologize. We started a little bit late, but Dr. Farber and Leslie, I'll let you all close it off, and I'm here for questions as well.
You had one slide that shows all the options, I think, the different materials.
Yeah, coming to it. I'm going back there.
Side by side.
So a lot of you I've met one-on-one. We've changed from the denture, the hybrid denture to this nano ceramic, and I've included the nano ceramic in that case fee. I just think it's a better option. It looks better, it's repairable, and it's got a 6-year warranty. So the fees that you saw there, we've included my restorative colleagues and I in the case fee. I've got another Jeff, thank you, and Leslie for setting this up. I have one question. To get their credits, how does that work for this course?
Through registration, we have all the info needed. So they'll be emailed the CE certificate within about 2 weeks.
Okay, great.
Nothing needed.
And I know that Peter may want to stay on with you guys, but if anybody has I put on the chat my email and my cell number, and you have Leslie's number and Jeff's number. They're great, and they've been around for us, and we're gonna have some other programs coming up. So I want to thank everyone for. And Jack Krauser has his hand up.
No.
Should we let him talk?
No.
All right.
I say yes.
Okay. Jack, you're in and out, Jack. Jack,
That's Jack.
are you there? Anybody
I love
else
you.
besides Jack have any questions? Anyway, all right, I'm going to sign off. Thank you, everyone, and I hope to see you soon. Stay healthy, stay safe. And
Dr. Moy, I'm here, Dr. Moy, if you want to talk.
And I just want to say that for my dentists around, I'm going to be having a meeting probably next week. I'll let you know, just to regroup, see how we're all doing, help each other out through this, and some protocols we're working on. So really stay healthy, Leslie and Jeff. Really a pleasure, and thank you both.
My
Thank
pleasure.
you.
Thanks, Alan.
Thanks.
Yeah.